Obviously, you're coming in on the cot. We strap the monitor up here and locks in. That way, if anything ever happens, we're involved in a collision, accident, anything like that, it doesn't become a projectile. Yeah. It's not setting up here, we hit a bump, it doesn't fall on the patient, because we like to help the patient, not create more harm for them. So we bring them in the back. Drug box down here, we keep extra medications up here. These are the common ones that we use quite a bit of, and a couple of them are the ones that we don't use as frequent, but we store them up there so we always have them. We have a suction unit here. Somebody's vomiting or they have blood in their airway or anything like that, we suction there, or we have a portable suction unit that we can take to the patient. All of our airway stuff stays up here. We are very, very blessed to have what's called a King Vision. So we get, when it comes time to take over somebody's airway, or they're in cardiac arrest, and we can't, they are very, very, what we call it, a tough intubation, which means they either have a lot of gunk in their airway, their anatomy doesn't allow us to actually visually see the cords, because what we're doing is when we intubate somebody, is we have, it's called a laryngoscope with a blade on the end of it. It actually drops down in the airway, lifts the tongue out of the way, and then what we're looking for is the vocal cords. So when we see those vocal cords, we pass a tube through them, and that goes into the trachea, and then we can go ahead and breathe for them. Well, sometimes you can't see that. So we have what's called a King Vision, which is actually very similar to the regular laryngoscope blade, except it goes on the end of a camera, and then I can drop this down in their oropharynx and turn it on, and now I can drop this down in their mouth, and then I can visualize that, and then if I take my tube, pass it down, and I can see it go right where I need it to go. So just another added tool that we have so we can provide the best care possible for our patients. Now we actually bought one of these off of the money that we raised at a pancake breakfast, and then I believe the city bought the other one. We have two of these, one on this truck and one on the second out truck. So, I mean, we like to pride ourselves in not needing it, because we like to go, you know, the ultimate way is to get it the old-fashioned way,
right?
Because that's what we're trained in. That's the skill, and you don't want to lose that skill, because there's going to be a day where this isn't going to work for you.
Yeah, right.
And you know, so we try to stay proficient in doing it I'll say the old-fashioned way. So this is how we go. This is our intubation kit. If we have to take over somebody's airway, this is the kit we're pulling out. So it looks like a mess, but so normally if we're going to intubate somebody, this is the tools we're using. So same way, it's got a little light on the end, but the same way I'm dropping this down, displacing the tongue, lifting up out of the way. It's going to put those vocal cords in vision, and then I can visually pass it through. And then there's a wide variety of sizes of tubes that we use on it. Just depends on how big the person is, how big, you know, their anatomy and everything else. It goes anywhere from a 6.0 tube to I think a 9.5, 9.0. These are just airway adjuncts that we use. It helps displace the tongue, so if somebody is unresponsive, they lose their muscle control. The tongue wants to flop in the back of the mouth, and it covers up that airway. So we insert one of these in their mouth, and it keeps the tongue out of the way, or we can drop one of these through their nose, and it allows air to get down through there. Really uncomfortable. These ones here we can put in a conscious patient. These ones here we can't, because when you drop it in the back of the throat, it induces the gag reflex, and then they're going to vomit, and then you just caused a whole new mess. That's something we have to do every quarter. We have to do intubation training, whether it be we have to do it on pediatric and adults. We have to document that stuff. It goes to our medical directors, so they know that we're staying proficient in our intubations. Now, if we get one, we do one in the field in that quarter. We don't have to do the training portion of it. That counts towards it. They just want us to have ample
so
opportunity to get it.
So if you do one at a scene, then
yep, if we do it at a scene, it counts towards our quarterly. But we still like to review everybody through, because there's a set way that you're supposed to do it. You know, there's steps you have to take, you know, going up to it. And it's just muscle memory.
Yeah.
You know, the more you do it, the more it's gonna, the easier it's gonna flow in the back of the truck. Now the medically assisted intubation that we do is where we actually, we talked earlier, give the medications to knock the respiratory drive down, and then we go ahead and place that tube for them. Our guys they train regularly on IV administration. Along with that, is we have patients that you can't get an IV on. Cardiac arrest patients, if the heart's not perfusing, the veins don't want to puff up like they normally would. So we have what's called an IO. This is actually a drill, and it actually drills into goes through the bone into the bone marrow, and then we can actually administer drugs that way. So it's just a little drill. We put one of these needles on the end of it, and it goes. We put one right here in the leg, or we go right here in the shoulder. So one of two spots we can go with it, and then, like I say, we can administer drugs that way. Can do that on a conscious person too.
Really?
Yeah.
I was just going to say, I imagine that's somebody that's out.
They claim it doesn't hurt to insert because it's going directly into bone. It hurts poking through, getting to the bone, but no more than what an IV would. The part that hurts the most is when we go to flush it. And I've done it on a couple conscious people, and what we do is we put a numbing agent in it first, and then it numbs. It's just lidocaine. Yeah. So we numb that area, and hopefully they don't scream near. They don't yell at us near.
Yeah.
I shouldn't say scream, because the last thing we want to do is hurt people. But sometimes you don't. Sometimes you don't have the choice.
Right.
Because ultimately, if you don't do that, then the outcome's not going to be very good for them.